Ну что у меня сбилось?
Так, давайте смотрим. Обновляем. Человек усилится сперва. И все нормально, у вас ничего не сбилось.
Нет, а что-то она улетела, потом я его вернулась. А, вот они, вижу, что они есть. Потом думаю, никого нет.
Их много.
Хорошо, спасибо. Birth traumatism of mother. This is selection of mother and fetus. You remember anatomic structure of external organs of family. If you look if labia, rectum, levator, area, coccyx, clitoris, maxillus, in this all muscles may be traumatism during delivery. First traumatism, rupture of perineum. Rupture of perineum may be different at some stage and may be rectovaginal septum. External anal sphincter may be ruptured. Tone ends on transverse perineal matrix. Tone ends of pubcavernosus muscle. Humeral ring. Risk factors may be loss stability of perineum tissues in case of primipara older than 30 scars of perineum, perineum. Malpresentation, head birth not by the least oblique diameter. In case of big head, big fetus, over maturity fetus, hydrocephalic. Operated delivery, contracted pelvis, not correct management of second period of delivery. You look different from stage rupture, first, second, third, and fourth stage. Symptoms of danger of rupture, hypertension of perineum, signs of edema of perineum after painless of perineum, in case of danger of rupture to do perineectomy. Classification. First degree, rupture only of back commissura. Second degree, rupture of back commissura, skin and muscles of perineum besides the sphincter and extons. Third degree, rupture of skin and muscles of perineum and sphincter and extons, and sometimes rupture of rectum. We look 3 degree, rupture of perineum. Rupture of perineum increase risk of birth infection diseases. One of symptoms of rupture is bleeding. It can be little or large. Rupture of perineum increases the risk of internal organs prolapse. Treatment. Organ suturing of the rupture. Women must don't sit down 1 month. No defecation during 5 to 6 days. She must have defecation help with enema. You look how maybe after delivery is rupture of perineum or absent. Rupture of vagina may be spontaneous or forced. Causes: not elastic vaginal walls, genital infantilism, malpresentation, past delivery, big fetus. Obstetrical help: to put in stitches, catgut, vicryl to the subcutaneous tissue and silk or vicryl to the skin. First sutures must be put about 5 mm under the superior corner of rupture. We look how may be treatment rupture of vagina. Hematomas of the sex organs of vagina. Clinical manifestation: Appearance of blue-red formation in region of external sex organs or vagina. Hematoma can be infected. You look picture hematoma after delivery. Between a vagina and in critical tissue, look big tissue named hematoma. And this is look hematoma, no picture. This is the look after delivery, and your centimeters near 6 centimeters. How may we treatment hematoma? If it is stable, obstetrical tactic is waiting. Women must lie in the bed with eyes on perineum. She must reactive vitamins B, C, calcium. If hematoma increases, surgical treatment is necessary. Rupture of cervix. Causes spontaneous. After inflammatory diseases and traumas of cervix, loss of stability, hypertension of it is marching, big fetus and malpresentation, fast delivery, contracted pelvis with pressing the cervix, causes FOST, after using obstetrical forceps and embryotomy. Hüluk-Heimer treatment. Classification. First degree. Rupture from 1 to 2 sites, not longer than 2 sm. Second degree. Rupture longer than 2 sm, but it do not pass to vaginal fornix. Third degree. Rupture passes to the fornix. Clinical manifestation. In case of first-second degree bleeding, usually is little. In case of third-degree bleeding, can be severe and internal into parametrium. Usually we can diagnose cause of bleeding after the evacuation or after birth. Treatment to put catgut or vicryl sutures. Rupture of the uterus. If all layers of uterine wall are ruptures, it is this rupture's uterus complete. If endometrium and myometrium ruptures and peritoneum stays, no hole, it is rupture uteri incomplete. Rupture can be localized in low segment, in corpus, in fundus, and rupture can be colpoparesis. We look rupture uterus. Etiology and pathogenesis. Rupture of bundle. Automechanic theory of rupture. He said that cause of rupture of uterus in delivery is disproportion between presented part of fetus and dimensions of pelvis. The situation can be in case of contracted pelvis, malposition, malpresentation, asynclitic insertion, big fetus, hydrocephaly, and oasa. If it's not possible to evacuate the fetus, strong birth activity starts. High segment of uterus became to put the fetus of the low segment. Fetus passes to thin hypertense segment. Contraction ring increases upper than the umbilicals and sometimes can be oblique. If strong birth activity continues, hypertense low segment rupture. Rupture of the uterus. You look this picture. Rupture of Verbov is an author of Ozach theory. He taught that healthy uterus don't ruptures and causes of rupture are pathological change in uterus wall. The causes can be scars after cesarean section, enucleation in the hysteromyomy, perforation after uterine abortion, degenerated and inflammatory process in the uterus and infantilism. Classification. During the pregnancy, during the delivery, spontaneous, forced, mixed, localization in fundus, localization in corpus, localization in low segment, colpoparesis, complete, incomplete, danger of rupture, beginning of rupture, ruptures. Clinical manifestation of danger of rupture. Rupture of bundle. Birth activity is very strong. Birth pains, labor pains are painful, sometimes spastic. Low segment in hyperextending sink and painful. Palpation of its painful too. Contraction ring is above the umbilicus and can be oblique. Ligamentum teres uterus are hypertensive and painful. Episioedema of cervix which progress of vagina and perineum. Urination is difficult. Not effective labor pushing in case of completed cervical dilatation and height above the pelvic inlet. Clinical manifestation of beginning of rupture. All that symptoms plus hemorrhagic discharge from birth canal, blood in urine, irritation of women and confirmed she is afraid, complaints of pain, bad condition of fetus, asphyxia. Clinical verbal ruptures of uterus as clinical danger of ruptures and clinical beginning of rupture. Strong birth activity is absent. Birth pains can be frequent, painful, but not very strong. All other symptoms are not such yet. Clinical manifestation of rupture. Sudden very acute pain in abdomen, stop of birth activity, decrease the severity of women condition shock and blood loss. Women is pale, pulse is rare and weak, arterial pressure decreases, nausea and vomiting is possible. Fetus pass to abdominal cavity and we can palpate small parts of fetus. Presented part were fixed. After rupture became available, palpation is absent. Bleeding can be external and internal. You look this picture. How may be rupture of the uterus stage. Treatment to stop the birth activity. In case of live fetus, to do the caesarean section urgently. In case of dead fetus, to do the embryotomy urgently. In case of the rupture, separation of uterus and treatment of shock and blood loss. This is look this full rupture of the uterus. After birth fistula can be orogenital and congenital. Present of the fistula result is disorder of all function of sex system. Etiology. This fistula is a result of pathological delivery, spontaneous and forced. Spontaneous appears became of necrosis of soft tissue of birth canal. It can be when the head stays in one plane of the pelvis more than 2 hours. Forced fistula appears in case of preparative delivery. Treatment surgical therapy. Rupture of pubis symphysis. During the pregnancy, articulation and ligament are impregnated by serous fluid. Very strong relaxation of symphysis is one of forms of toxemia of pregnancy normally. Extension of symphysis can be no more than 5 mm. It can be ruptured in case of pathological and operated delivery. In case of ruptures of symphysis, will be bleeding during bladder. Clitoris and urethra can be traumatized. You look, this is rupture symphysis, rentgenogram and MRT. Clinical manifestation: pain in pubic region, disorder of pacing. Tissues pubis are edematical and palpation is painful. Diagnosis with the HELP X-ray. Treatment: in department during 3 to 5 weeks. Special position, vitamins, calcium, rest. In case of progressive hematoma, surgical treatment. Birth traumatism of fetus. Local damage of fetus tissue during fetal descent act, which rose up as a result of preparative of mechanical force directly on a fetus, but not on the placenta umbilical cord, and shows up breaks, fractures, dislocation, laying out smushed of the tissues. The damage degree of fetus depends from degree of premature or mature fetus, degree of formation and size of the skull, degree of formation of the cerebral flux and cerebral tentorium, degree of maternity canal tissues, form and size of pelvis, violation of moving apart of maternity waist, tissues and the premature break of fetus bubble, dynamics maternity act, steady duration of the fetus head in the uterus neck change. Morphological signs of birth surgery: labor tumor, hemorrhages, esophageal hematoma, hemorrhage in the cranial cavity, hemorrhages in the cerebral ventricles, damage of cranial bones. Head injury. The fetus of infant can sustain a number of traumatic head injuries during labor or delivery. They can be external and obvious of intracranial and even covent. Some are spontaneous, where others associated with instrumental deliveries. They were reviewed recently by Documentis and Erkoma. Look, this picture is about a head with injury. Spontaneous intracranial hemorrhage. Fetal or neonatal intracranial hemorrhage can occur at any in several cities. Isolating intraventricular hemorrhage intergeminal matrix without associated supracranial or subdural bleeding is the most common type of a cranial hemorrhage. It is used in intraventricular hemorrhage. It usually occurs spontaneously as a result of immaturity and generally does not result from traumatic delivery or obstetrical factors. Infants weighing less than 1,500 grams are most susceptible. Major types of intracranial hemorrhage in the newborn. Type gestational, incidence and severity, cause and pathogenesis. Term preterm labor may be in case structural uncommon serious, venous dose trauma common. In the more preterm labor, common benign excited severity intram tem, intracerebral in the more preterm term, uncommon serious, multifactorial, intraventricular, preterm, common benign, general matrix multifactorial, marginalization in the more term preterm, uncommon variable trauma hemorrhagic. Traumatic intraventricular hemorrhage. This trauma is not a common cause of intracranial hemorrhage. The elimination of difficult forceps operation and operated management of breech delivery have contributed significantly to a reduction in the incidence of all birth injuries. For example, in the more than 1,090 strangulation infants greater than 1 or 2,500 gram born in the United Kingdom in 1994 and 1995. O'Mahony colleges reported an incidence of deaths from mechanical birth injury to be 3.1 per 100 births thousand. Isolated and captured 23 morbidity from process deliveries, appropriated use of forceps or vacuum delivery does not lead to increased intracranial hemorrhage or other neonatal injury. Infants suffering intracranial hemorrhage from mechanical injury, such as subdural hemorrhage from tentorial tears or massive intratentorial hemorrhage, have neurological abnormalities from the time of birth. Severely affected infants have stupor or coma, nodular rigidity, and oikostonus that worsen over minutes to hours. Some infants who are born depressed appear to improve until accessibility 12 hours age, but then drowsing, apathy, feeble cry, pallor failure or nose dyspnea, cyanosis, vomiting, and convulsion become invited. Subchorionic hemorrhage is usually minor with no symptoms, but seizures within an enteral period may manifest. In some infants, there is catastrophic deterioration. Sonography, imaging of the head are useful for diagnosis also have contributed appreciable to an understanding of the etiology and frequency of some forms of intracranial hemorrhage. What is cephalohematoma? If you look this picture, Cephalohematoma. Hematoma may not be apparent until hours after delivery, when bleeding sufficient to raise the periosteum has occurred, and often grows larger, disappearing only after weeks or even months. The infant may become anemic. Nerve injuries, spine injury, overstretching of the spine cord initiated hemorrhage, may follow excessive traction during delivery, and there may be actual fractures or dislocation of the vertebrae. Brachial plexopathy. These injuries are relatively common and indicated between 1 in 500 to 1 in 1000 term births. Basket Associated 2007, Journal and Colleges 2006. Three types of brachial plexus damage have been described. Damage to the upper plexus is called ERP or dorsal paralysis and infus C5 and C6 and conversely C7. Injury lead to paralysis of the deltoid and infraspinal muscles and the flexor muscles of the forearm. The affected arm is held straight, internally rotated, the elbow is extended, and the wrist and fingers flexed. Function of the fingers usually is retained. Because lateral head traction is frequently employed to effect delivery of the shoulders is normal vertex presentation. Yet paralysis can follow even deliveries that not apparent difficult. Maybe brachial plexus injury. Nerves between the neck and shoulders are stretched compressed in the during birth. Facial paralysis. In these deliveries, facial nerve damage can be caused by pressure exerted by the posterior blade when forceps have been placed obliquely on the fetal head. In these cases, forceps marks indicate the cause of injury. Spontaneous recovery within a few days in the ruler. Injuries to the sixth cranial nerve with resulting lateral rectus ocular muscles paralysis following operative vaginal delivery have also been reported. Plus trauma, perinatal nervus, brachial plexus. This may be if after delivery pathological of nervus. Skeletal and muscles injuries. Fractures. Clavicular fractures are common, unpredictable, and intraorbital complication of normal birth. Humeral fractures are not common. Difficult incoated is the delivery of the shoulders, encephalic deliveries, and fecosternal arms in bridge deliveries often produce such fractures. Femoral fractures are relatively rarer and usually associated with bridge delivery. Mandibular. The fracture likely resulted from compression of the skull against the sacral promontory, from lifting hand pressure by the surgeon, or from upward hand pressure by an associated who helped to push the head out of the birth canal and delivery. You look top of a sternum, vertebrate clavicle. Just after rupture. Muscles injuries. The sternocleidomastoid muscle may be injured, particularly during bridge delivery. There may be a tear of the muscle of the facial chest leading to a hematoma and gradual circular contraction. As the neck lengthens in the process of normal growth, the head is gradually turned toward the site of injury, a condition known as tortuousness. The damaged muscle is less elastic and does not elongate at the same rate as its normal contractile counterpart. Rumor 1954 reported that 27 of 44 infants showing this deformation had been delivered by bridge or tonal public version. He postulated that lateral hyperextension sufficient to rupture the sternocleidomastoid may occur after common head passes over the sacral promontory. This look where injured muscles, sternocleidomastoideum.